Hello, good evening. Welcome to Renew the African Mindset, otherwise known as RAM. Renew the African Mindset is actually an organization that seeks to redress some of the issues which Africans hardly talk about in the open. It's a non-profit making organization established in the UK in 2012. The reason for setting it up is to ensure that we are educated on some issues which we do not talk about in the open due to our traditional values, cultural beliefs, and background, and that is what makes up your mindset. Because there is also the culture of silence, especially where health related matters are concerned. A lot of Africans don't share that, and this is actually a very sensitive topic. The When people hear about the word cancer or the C word, people just they sort of like have this fear. Yes, it is good to be fearful of a condition which you do not know about. However, when we open up our mindsets and we talk about health issues like this, we seek information, we seek support in the right places, and thereby preventing loss of lives. So that's the reason why Renewing the African Mindset has been set up, to bring together Africans who would address issues which are prevalent within the African community. So, with that, is to have some sort of positive achievement in things that we do. Another reason why RAM exists is to promote collaboration between agencies or even individuals, and then to promote success stories within the diaspora. But today we're going to talk about our health. And it is very important. When we talk about breast cancer, there's so many taboos. In fact, when people talk about breast cancer, a lot of people always think that it's not something you talk about in the open. And today we want to dispel some myths. We want to stigmatize what people always hold so dear, thinking nobody should know about it. Because if you don't tell anybody about your problem, how are you going to get a solution to it? And then again, we also have the religious angle to it when we talk about things like breast cancer. So today, we are going to address this issue. I was reading an article. It says 1 in 8 women will get breast cancer. That's according to the UK statistics. Whether that is true or not, we don't know. But today we're going to address this issue. We want to tackle it. So today we have about 3 oncologists on board as members of the panel. We have a lady who is going to share a personal journey with us with breast cancer. And then we also have somebody from Macmillan Support Group and in the United Kingdom here. And we also have a representative of one of the major organizations, support organizations in Nigeria, who would also tell us about what they do in terms of helping breast cancer patients. So without further ado, I'll go straight into introducing our first panelist. This lady, she's the director of medical oncology, Max Healthcare, New Delhi in India. She currently works as a consultant medical oncologist in gastrointestinal and breast cancer. She's currently the resident of the oncology section of the Royal Society of Medicine. She is an honorary consultant in Queen Mary's University, London. She previously worked at the Bats Health NHS Trust in London and Royal Marsden NHS Foundation Trust. She's had more than 2 decades experience as a medical consultant and medical oncologist, both in India and the UK. She's published more than 120 papers in national and international journals and lectures globally. She's edited 3 books on cancer, namely Cancer Questions Answered, Chemotherapy in Gastrointestinal Cancers, and Modern GI, also known as gastrointestinal intestinal oncology. She has received numerous awards for her expertise, which includes the BAT Heroes Award for Education in 2018. Please join me in welcoming Dr. Bhavna Sirohi. Welcome, Dr. Bhavna.
Thank you. Thank you for having me here. It's a pleasure to be here.
Thank you so much. I'm going to start off with you. When we hear about breast cancer, we also want to dispel some myths as well. However, let's start from the basics. What is breast cancer?
So, I mean, I think when you describe breast cancer, it is a cancer of the breast and arising in the breast. And so, cancer is basically when a cell goes haywire and starts dividing in a way which is not normal. Normally, one cell produces two cells, but due to either genes or environmental influence, the cell doesn't divide normally and divides abnormally, and that leads to cancer.
Right. Okay. Is every lump cancerous?
No, not every lump is cancerous. In fact, most of the lumps are non cancerous. But it is important to be aware that if you have a lump, you must take advice and get it checked.
Okay. Um, is it true to say that it's a disease or is it a condition?
So I think it's. I mean, you can describe it in either way, but it is a medical condition, I would say, which is easily treatable if detected early. Like you have diabetes and high blood pressure, which are not curable, and but breast cancer is highly curable if it is detected early. And the good thing about breast cancer is that by various screening methods, or one can detect it in precancerous stages before it becomes cancer as well.
Oh, you mentioned three cancerous stages. Could you tell us about the three cancerous stages?
So there are some cancers which lend themselves to screening. By screening, I mean is that a person who does not have any problems, they go for a health checkup and have an X-ray of the breast done, which is called a mammogram, and that helps us in detecting cancer early. And by stage of cancer, we mean stage zero, or the precancerous stage is on mammogram. Sometimes we see some dots, which we call microcalcifications, which we would take a biopsy or put a needle in and check it, and it's called ductal carcinoma in situ. It is not cancer, but that also needs to be treated. Stage 1 cancer is when the cancer is confined to the breast. Then the next stage is when the size of the breast cancer is slightly bigger, that's stage 2. And when it goes to the lymph nodes under the arm, it becomes stage 3 when it's gone out of the organ. And when it goes to distant places like lungs or liver, it becomes stage 4.
Wow. Okay. What are the causes of breast cancer?
So I think there are some risk factors. By risk factors, I mean is that it's not that if you have those, you will definitely get breast cancer, but the likelihood is more if any of these is present. And there are some what we call non-modifiable factors. Some of them are modifiable. By non-modifiable, I mean is age, family history, that is the genes, and your reproductive history, or these are things which you have no control of, so they're non-modifiable. But there are certain things which you have control of, like your diet. So the reason why the incidence of breast cancer is rising in countries like India, where like I'm based in Delhi now, is because we are becoming more westernized. So we are not exercising more, we are working, we are not breastfeeding. So these are risk factors for developing breast cancer. And diet plays a very important role. Ladies who exercise, the risks of developing breast cancer are slightly lower in those women. Especially, WHO recommends about 30 minutes of exercise every day. Drinking alcohol, smoking, these also increase the risk of breast cancer. So I think these are the main things. Oral contraceptive pills or using hormone replacement therapy for a long time also increase your risk of developing breast cancer.
Right. What about the symptoms? What should we be looking out for?
So I think it's very important for every woman. All of us should know what our family history is. Know that, if your mother or your grandmother or your maternal aunt or your cousin sisters had any type of cancer, or if they've had breast cancer or ovarian cancer, it's important to know, because then the screening for the child starts at least a decade earlier than when the mother developed it. So it's important to be aware about your family history. That's very important. The symptoms for breast cancer are mainly most patients present with a painless lump, but that does not mean that you may not have pain. So you may present with a painful lump as well. So it's very important to know what is normal for you. So, stand in front of the mirror, look at the contour of your breast. Most of us may have one breast which is larger than the other. See if the nipple is retracted, if you have a nipple discharge, if you have any redness, or if the contour is looking slightly differently. So if there's any change, if there's dimpling of the skin on the nipple, reddening of the skin, so these are all the symptoms, or if you have a lump under the arm. So these are the main symptoms that ladies would present with. And then, further investigations need to be done. It may be a simple infection, it may be a cyst, it may be a fibroadenoma, which is not cancer. So most of us have some lumps and bumps called fibroadenomas and fibroadenosis. But it's important that, if there is something new, you don't ignore that, you get it checked out.
Okay. Can you actually prevent cancer at all? Apart from
Yeah,
the diets that you mentioned.
yeah. So I mean, like at least, like I worked in London for a long time. By risk factors, I mean that we know, sir, modifiable means these are in your hands. There are certain factors which, if you do and do regularly, and it will prevent cancer. So not smoking, not having alcohol. So I have this ABCD of prevention of cancer. A is avoid alcohol, tobacco. B is vaccinated. It doesn't apply to breast cancer, but it applies to other women's cancer, the HPV vaccine or hepatitis B. C is, I say, calm and meditation, because stress is another factor, which all of us have in our lives, and this also helps in preventing. D is diet. By diet, I mean, you must avoid saturated fats. By saturated fats, I mean anything that sets. Let's say butter, margarine, coconut oil. These are all saturated fats. But vegetable oils, anything that doesn't set when it's cold, is a polyunsaturated fat, which is good. Having enough vegetables and fruits in your diet, having a balance of protein, carbohydrates in your diet is very important. These diet, E is exercise, at least 30 minutes daily. F is know your family history. And S is screening for breast cancer. At the age of 15, UK, you get a call for a mammogram.
Yeah.
It's available on the NHS. You must access that. What I learned when I was in UK is that the Asian population and the Afro-Caribbean population would, despite having access to it, do not go for these tests, sadly. So I think it's very important that you take up this. With S, I would also say sleep. There was a study done in Spain which showed that if you have 2 hours between your last meal and sleep, or if you sleep after 9 p.m., the risk of breast cancer is 25% higher. So, sleep on time, eat on time, don't eat late. So all of these things would prevent breast cancer as well.
All right. Thank you so much for that, Dr. Sirohi. We're going to come back to you. Now, over to you, Mr. Ogedegbe. Now, I need to read out his profile. It's a long one, but he's told me that I need to keep it short. He was trained in Nigeria and also in the United Kingdom. He received his doctorate from the University of London. Research interest is in biology of breast cancer and how it affects prognosis. His passion is explaining the pathological process of diseases and ensuring minority groups engage with healthcare provision in the United Kingdom, leading to improved healthcare outcomes. For nearly 2 decades, he has been a consultant on plastic breast, general and head surgeon at King George's Hospital, Goodmayes in Essex. Welcome, Mr. Ogedegbe.
Thank you.
Right. I need to ask you technical questions now. Let me just first of all pick on what you said here. Consultant oncoplastic breast. What does that mean in layman's term?
So in layman's terms, essentially, in the very old days.
Let's be politically correct now.
No, yeah, that's fine. In the old days, when you treated women with breast cancer,
yes.
The outcomes were very, very mutilating. And the only treatment available at the time was to have a woman's breast removed and nothing else. Over time, we have done lots of studies, and we've been able to prove that without removing the breast, it's still possible to cure people with breast cancer, and therefore leaving a breast which has a form and a shape which is aesthetically pleasing. We also know that even if you were to remove part of the breast, it is possible via some surgical techniques to replace parts of the breast you have removed with either the woman's own tissue or using artificial material like an implant. And that's how we coined the phrase oncoplastic. So the onco is cancer, that's treating cancer, and the plastic is the cosmetic means by which the cosmetic techniques we introduce in trying to restore the form, the shape, and the aesthetic appearance of the breast.
Right. What does mastectomy mean?
Mastectomy in simple language is removal of the breast and leaving a woman with without a breast, essentially. And there are a variety of forms of mastectomy where you could either remove the breast alone and leave enough skin to help you try and build the breast up in future, or you can remove the breast, remove some lymph nodes in the armpit, or in the old days, remove the breast, remove the lymph nodes, and remove some lymph nodes behind the rib. So there are a variety of descriptions to help us classify the different kinds of mastectomy. But in simple language, mastectomy is essentially just removing the breast on its own, not doing anything to the muscles or not doing anything to the lymph nodes. That's the glands in the armpit.
Right. So when you make the decision to remove the breast, that is actually the ultimate to save that life, or could it be prevented? Say, for example, somebody is saying, no, I don't want my breast removed. What other form of treatment can they have?
So the first thing to say is that when a diagnosis of breast cancer is made, there are essentially 4, maybe now 5 methods of treatment. Surgery, where the cancer is essentially caught out, either removing the breast or not removing the breast, where we call that conservative surgery. And the other means are using chemotherapy, where a patient is injected with medicines through the vein, or radiotherapy, where X-rays are shone onto the breast to try and kill any cancer cells that are there. And then we have what we call endocrine therapy, where patients are given some medicines which manipulate to affect the hormones to reduce the risk of the breast cancer coming back. And nowadays, we now have different treatments we are called smart drugs. We now know that some breast cancer express certain proteins or DNA, and there are specific medicines that can now be used to deal with those patients who have those sort of cancers. So surgery by itself is only one form of treating breast cancer. And more often than not, it's a combination of treatment for most patients. Surgery, in some cases, is curable. And my colleague who spoke earlier did mention something called non-invasive breast cancer, or ductal carcinoma in situ, DCIS, where the cancer cells are still located within the tubes in the ducts and they haven't come out. Now, under those circumstances, if you were to perform an operation, a good proportion of those patients can be cured from their cancer.
Right. Okay. So, what's the difference between chemotherapy, radiation, and I think there is another one? Okay, just tell me the various forms of treatment that they can have. The surgery, I think, is the one you just mentioned, radiotherapy and chemotherapy.
So radiotherapy essentially means shining X-rays onto the breast or any other organ that has cancer, and you use a machine called the linear accelerator. And prior to having radiotherapy, you have something called planning, where the patient goes in, and usually a CT scan is used to try and map out the area where you want the radiotherapy to be directed to reduce the adverse effects.
Right.
And generally, it lasts for between 3 weeks to 5 weeks, depending on what sort of radiotherapy the patient is having and the extent of disease.
Right.
And then we come to chemotherapy, which is the introduction of chemicals into the veins, into the bloodstream of patients to try and kill any cancer cells which might be floating around, which we may or not have been able to identify prior to initiating treatment. And then we have what we call endocrine therapy or hormone therapy, because we know that about 60% of breast cancers express a protein called estrogen on the cells.
Right.
And there are various medicines, all the families anti-estrogens, which tend to attach themselves to the receptors of those proteins, and therefore prevents the breast cancer from either getting larger or going elsewhere. And in some cases, it reduces the chances of the cancer coming back. And for patients who have had breast cancer, the common tablets a lot of people would have heard is something called tamoxifen, which we've used for the best part of 30 years now. And that particular medicine is for endocrine or hormonal therapy for breast cancer. And lately, we have identified some other protein material, and one of them is called human epidermal receptor growth factor. In simple language, it's called HER2. And there is a medicine called Herceptin, which is targeted to patients who express that particular protein. And we know that when patients express that protein and have the medicine, the chances of the cancer coming back are significantly reduced.
Right. There is a question I'd like to ask you here, which a lot of people always talk about. To me, I think it's a myth. Is it true to say that it's only women who get breast cancer?
No, that is inaccurate. We do know that men and women alike get breast cancer, and the incidence of cancer in men is 1%. So 1% of all cancers happen in men.
Right.
And the treatment essentially is the same as the treatment in women. But we also know that most men who develop breast cancer tend to have a genetic risk for developing breast cancer.
Right. Okay. Even hearing what you're saying is very frightening. Do the patients receive counseling before they go in for surgery?
So the journey with regards to diagnosis and treatment is, at least I can speak for the United Kingdom, and I'm sure in some parts of the United States as well and Europe, it's very, very well planned and well coordinated. And so the patient initially identifies a problem, goes and sees their family doctor, who then refers them to a specialist like myself. So they come to what we describe as a one-stop breast clinic, where you have a clinical examination, you have investigations called a mammography, which is X-ray of the breast, and an ultrasound scan, and sometimes a biopsy if it's necessary. And at that consultation, we don't get all the results back, so we discuss the possible outcomes with the patient, and then plan for the patient to come back and see us in the clinic when the results are available. Now, at that clinic appointment, we introduce the patient to somebody called the clinical nurse specialist, who essentially coordinates the care. And the clinical nurse specialist is that person who links the patient with the surgeon, the oncologist, the pathologist, or the radiologist. So we have a multidisciplinary group called the MDT, where we have all the key members there who treat breast or other cancers. And it's at that point when we get all the information from the investigations, from the examination, and then we then discuss what the best possible treatment for that patient is, everyone contributing. The patient then comes back to our outpatient clinic when we have all the results. If it unfortunately turns out to be breast cancer, we share the diagnosis with them and emphasize that most breast cancers are curable, and outline what the treatment strategy is, and give the patient a good sort of half an hour to one, try and digest information, ask whatever questions they need to ask, and then spend perhaps a similar amount of time with the clinical nurse specialist in a very quiet room, going through essentially what the patient has heard from the surgeon.
Right.
And usually, in most cases, the first treatment is surgery. So we then schedule an operation, ensuring that the patient understands what the operation is for, what the likely benefits are, what the adverse effects are, and then we outline what other treatment may be required. If it's further surgery, which sometimes happens, or chemotherapy, radiotherapy, or the use of hormonal treatment to try and reduce the risk of the cancer coming back. So we try and build a lot of support around the patient, because we know that most people who get a diagnosis of cancer are quite fragile. And it's important to try and reassure them that there are people who are appropriately trained to try and deliver the care that they require. And more often than not, a cure is possible. But more than that, we also encourage patients to join some of our support groups, to get in contact with people who have had a similar diagnosis and a similar treatment, and who have actually had a good outcome. Because there's no better advertisement than somebody who has had the experience you're about to undergo. And that is very, very, very reassuring for patients.
One last question, at least for now, that I just want to ask you is that you are focused on the patient. And I remember that I spoke with a breast cancer survivor. She said to me, they're always focusing on the patients. But what about the carers? Do you also bring in family members for counseling, or you don't do things like that once you've diagnosed that person with breast cancer?
More often than not, at the time of diagnosis, a patient comes with a family member. And so usually it's the spouse or the child of the patient. And at that time, we share the information with both of them and give the family member the opportunity to ask questions. But what we tend to focus on more than anything else, not the family member, yes, but we try to ensure that the patient has support at home. Because quite a few people, when they find themselves on their own, their minds always begin to wander. And it's important to know what sort of support they have at home. For those patients who do not have a good family environment or social structure around them, then we tend to provide a sort of body system for them, either within the organization or out of the organization, so that they are not entirely isolated, especially when going through their treatment. Okay. So the family members, we would not ordinarily send them all for counseling, but if in the course of our conversations we identify that a need might arise for counseling, then we go down that route.
Okay, thank you so much for that information. Very informative. The next person I'll call on is also another oncologist, and we are really glad that he stepped in at the very last minute, because we thought we were going to have Dr. Fatiregu. She's not here, but this person is highly qualified. He's a professor of surgery, surgical oncologist, Abia State University, and also Abia State University Teaching Hospital in Nigeria. He is the chairman of Surgical Outreach Committee, West African College of Surgeons. He is a board member and the African representative of the Pan-African Academy of Christian Surgeons. Since January 1996, he has been the director of residency training program at Abia State University. He's conducted numerous peer reviews of research papers on breast cancer, including African breast cancer disparities in outcomes, ABCDO. I'm sure he's going to explain that. He's received numerous awards, including the American Society of Clinical Oncology International Development Education Award. He has had collaboration with Africans in the diaspora and other professionals from all over the world in good science on the biology of cancers in Africans, and to develop biomarkers and translational agents that specifically target molecular pathways in cancer, thus reducing the burden of cancers in Africa. Please welcome Professor Charles Adeyinka Adisa. I'm sure Professor Charles Adeyinka Adisa is there.
Hello, Anfu. Nice seeing you.
Thank you so much for coming. Very much appreciated that you stepped in at the very last minute. We truly appreciate that. Now, I have some questions for you because I was reading some which a layperson like myself will call jargon, but I'm sure it's to actually help the African community. You said here you've conducted peer reviews of numerous research papers, and of course, you've written several publications, including the African Breast Cancer Disparities in Outcomes, ABCDO. What does that mean?
Thank you for me. ABCDO is a collaborative research between the International Agency for Cancer Research, that's the main body of the WHO in terms of cancer research,
Right.
and it's situated in Lyon, in France.
Right.
We collaborated with them, and we had about 5 different African countries signing on onto the collaboration to look at, because the story we are very well. Yes. Let's give you a comment. Sorry, I had a little distraction. Yeah. Good day. So African, please don't make much noise because I'm on YouTube. So Africans generally account for fewer number of cancers, breast cancer worldwide.
Right.
But they also, unfortunately, they account for the highest number of the mortality, of the deaths.
Wow.
So that is a disparity on its own between Africans and Caucasians. And even in the United States, you discover that the African Americans have a higher mortality compared to the other races. Now, the purpose of the research was to find out if within the African continent itself, whether there are variabilities in outcome, not just between Africans and other races, but if within the African system, we have some disparities in outcome, and if we could identify what is driving those disparities, perhaps we could be able to get some policy or interventions that will reduce the mortality. So we have the ABCDO in Nigeria. We have 2 centers in Nigeria, Abia State and Imo State. We have one in Namibia. We have 1 center in Zambia, Uganda, and South Africa. So these are the various countries that are conducting the research, and I'm the PI in Nigeria.
Right. So, are you trying to say to me that up till now, they haven't been able to find out why there is a high mortality rate in Black people or Africans?
Oh, no, there are several reasons why the mortality in Africa is higher, or even in African Americans is higher. Basically, there are 2 ways of looking at it. One is the biology of the cancer itself. We know that cancers generally are not uniform.
Right.
Somebody may have a milder form of the same cancer, whilst another person has a very aggressive type of cancer. So the first question we're looking at is there a possibility that the cancer is biologically more aggressive than what you have in the other races? That's the first aspect. Then the second aspect, are there cultural, institutional, financial, or social factors that contribute to the death, the increased death or mortality among the African cohort? So those are the things we examined. In my first study on biology of breast cancer. I actually collaborated with Dr. Laura Isaman, who's a breast surgeon in the University of San Francisco, University of California, San Francisco.
Mm-hmm.
And we look at the breast cancer of, the specimens of, and when we look at them, there are a number of factors we notice.
Mm-hmm.
Now, there are several parameters we use to classify how bad the tumor is and how less aggressive that tumor is.
Right.
This includes the estrogen, what we call the hormone receptor status.
Right.
So we check the hormone receptor status. Dr. Ogedengbe
Mm-hmm.
mentioned ER,
Mm-hmm.
ER receptor. We look at that as well. And specifically, we look for another marker
Right.
of bad disease,
Yes.
which is what we call proliferating macrophages.
Mm-hmm.
Macrophages are white blood cells.
Right.
It's a subset of white blood cells. And some of them are expressed in high content
Mm-hmm.
in women with breast cancer.
Right.
So when we look at that figure and compare it with African Americans
Mm-hmm.
and the Caucasians in the US,
Mm-hmm.
we discovered that the Nigerian women have about 70 or 80% of our patients were all estrogen receptor, progesterone receptor, HER2 receptor negative.
Right.
So there were a good number of them were what we call triple negative tumors. And triple negative tumors generally are bad tumors in
Right.
terms of outcome and prognosis.
Right.
So those are, and then we also noticed that the proliferating macrophages were overexpressed in the Nigerian patients.
Right.
So when you compare the three different groups, the Nigerians, the African Americans, the Caucasians, we discovered that it's those bad predictors
Yes.
of aggressive cancer were commoner in Africans, followed by African American, and less in the Caucasian population. So we're able to establish that yes, there is definitely some form of aggressive tumor that the African women are exposed to.
Yeah.
Then for the ABCDO program, the study, we look at a lot of factors. Number one factor we discovered was that within those 5 African countries, there was a gross disparity in outcome, with Nigeria faring worst, followed by Uganda, Zambia, Namibia. South Africa has a very good outcome, especially, South Africa is like a multiracial country.
Yes.
So we stratified the population in South Africa again. We stratified those who are whites and those who are Africans.
Yes.
And we discovered that it's the same pattern you have in the US.
Right.
The blacks have a worse prognosis, worse outcome than the whites in South Africa. The same thing in Namibia. Namibia also has a significant population of whites.
Right.
So it was the same story. The whites in Namibia did much better than the blacks in Namibia. And when you look at countries that don't have a significant white population, like Nigeria, Uganda, Zambia, we discovered that even within those 3 countries, there was still a lot of disparity. And one of the critical factors we discovered was, one, education. The more educated you are, the higher the chance that you present with a disease that presents early, not an advanced disease.
Right.
Secondly, we discovered that marriage also plays a very important role. The married ladies with breast cancer present earlier than their single counterparts.
Why is that the case?
Yes, that's what we discovered in our
Why is
study.
that the case?
We found that the reason was there was more support for the married woman than for the single woman. There was a lot of support from the family and everybody around. And a young person also, the fear that she will lose her breast, and that reduces her chance of getting married. So a number of them, just carry on as if nothing is there, especially because breast cancer is usually, in the early stages, it's usually painless. So most people feel, well, just a lump, it's not disturbing me. So that's one factor. But the major factor we discovered was also the health insurance policy in those 3 different countries.
Right.
Nigeria has the worst health insurance policy. Less than 5% of the population is covered by any public or private health insurance policy. Uganda has about 30% to 40% health insurance, while Namibia has almost 100% health insurance. So that also reflected Nigeria had the worst outcome.
Wow.
Because people have to pay out of pocket, and that's at the experience, the painful experience I had as an oncologist. You start a patient on chemo, and they take 1 or 2 doses and they default because they couldn't afford the cost of the treatment. Right. So these are some of the issues.
Okay, thank you so much for that. I just have very some questions which are specific to to some of the things you mentioned, and also to Nigeria, because you've used Nigeria as an example, having the poorest sort of like healthcare system. So I mean, there's no point in me just saying what's the perception of the healthcare system in Nigeria. I mean, it's a no-go area. So when you talk about things like this, is there any difference in the recovery stage of patients, or is it dependent on where the cancer is found in the breast?
Please, can you repeat that question?
Any difference in the recovery stage?
In the early stage?
Yeah, at any stage, the recovery stage of anybody who's been through, who's had breast cancer, or does it depend on wherever it's been found on the body? On the breast.
No, not necessarily. What affects the prognosis or outcome is the stage at which the cancer was discovered. Not necessarily, not whether it's on the right side of the breast, or the left side of the breast, or the upper part or lower part of the breast. The basic factor is that a good number of the patients, in fact, 70% of the patients come with advanced disease.
Wow.
That's the basic thing. Unlike in the developed world, that you have virtually 80–90% of people coming with early disease that are operable, treatable, curable. Majority of our patients come with incurable disease.
So obviously there is nothing like mandatory breast screening in Nigeria.
No, there is not. It's
what about,
most of the screening are just opportunistic screening by individuals or charities.
Right. Interesting. There is one thing that I wanted to ask as well. People have come up with some funny taboos, which includes eating yam. Would you say that it helps to reduce the risk of getting breast cancer, or would you say it increases it? Because we've heard a lot of all this going around.
So that's a very interesting one. I'm just hearing that for the first time, that if you eat yam, you develop breast cancer. Of course, there are a lot of funny beliefs. Some people believe it's juju, that's African medicine that people use, some kind of diabolical things. Some people believe that it's in fact, there was a variety of response when we asked women in our study, what do you think is responsible for breast cancer? Majority of them felt that it's because of bra. Some people felt it's wearing bra predisposes you to breast cancer. Some felt that
maybe I might even ask Dr. Sirohi whether that is true. Would you say, with all the disparities you've been talking about, that African women are prone to breast cancer? Would you say that?
Uh,
No, what I said was that African women account for a smaller population of the
Okay.
breast cancer.
Oh, okay.
The breast cancer, in fact, in developing world, breast cancer is not as common as you
Right.
have in Caucasians,
Right.
but they account for the greater proportion of the deaths.
Okay. All right.
Yes.
Thank you so much for that. We'll come back to you in a minute. Let me just quickly go back to Dr. Sirohi. I just want to ask this question. Being a woman, would you say that it is true that the type of the bra you wear would cause breast cancer? Would that be right?
no, I think that there is no evidence that whatever type of bra you wear causes breast cancer at all.
Okay. Would you say that some people will say to you that this is one of the taboos? Only Caucasians suffer from breast cancer.
So I think I agree with my colleague that the incidence, that means the number of new patients developing breast cancer in Asian women, in African women, is much less compared to Caucasian women. So the incidence there is 1 in 7 women will develop breast cancer, but I mean we don't have the exact statistics, but in developing world or low and middle income group countries, I would say it's 1 in 30 to 35 women will develop breast cancer. It varies from region to region. It's because I think because of the various reproductive factors that
Right.
that most women would breastfeed,
Mm-hmm.
they would have children. So being nulliparous, not having children, is also a risk for breast cancer. And also generally the use of alcohol, tobacco, obesity is much less because of physical activity, physical, like most in India, I can say that most of the women, 70% of people live in villages where people are very active. It
Right.
is the westernization of or what I would say globalization of Africa and countries like India, which has actually increased the incidence of breast cancer.
Okay.
But I also agree that the type of breast cancer that African women have is slightly different compared to the Caucasian women, in that there are more women who have triple negative breast cancer, and they are diagnosed late.
Okay. Two more. I know I'm not sure whether to call them taboos, but I'll still ask the question. You have to be 50 years old before you can get breast cancer.
No, you don't have to be breast cancer. I'm currently treating a 22-year-old girl. So, and when I was in Northeast London, I treated a lot of women who were very young, in their mid 20s, late 20s, 30s. And we actually set up a group for young women with breast cancer, women who were less than 40 years of age. So that is not right that if you're 50. The only downside of that is the screening in UK starts at the age of 50. I
Right.
think the government is doing, and we know that because of the population matrix that we have in countries like India or in Africa, the population is young.
Yeah.
So that is why the diagnosis of cancer is also a decade earlier in these women. So screening doesn't start early in this, and I would not recommend doing a mammogram at the age of 40 because young women have dense breasts. So a mammogram does not yield good information.
Okay. Would you say that after the treatment of breast cancer, it could cause infertility?
So, not all treatments for breast cancer would cause infertility, and we have something called oncofertility, where if you there are some treatments like for breast cancer, like chemotherapy, they can cause infertility, but we can mitigate that by doing various things like. If a lady has a partner or husband, then we can preserve it. We can do embryo cryopreservation. So we do fertility counseling before patients start chemotherapy, and we can also give an injection which suppresses the ovaries before they start chemotherapy. So there are various things that can be done to mitigate that.
Okay.
But yes, chemotherapy can cause that, but breast cancer itself doesn't cause, early breast cancer doesn't cause infertility.
Okay. One last question for you. You have to have cancer in your family before you can get it. Is that true?
No, no, that is also a myth, because hereditary breast cancer is, I would say, accounts for less than 5% of breast cancer. So it is not very common.
Okay. Thank you very much, Dr. Sirohe. Let me just quickly flip back to you, Professor Adisa. As an oncologist based in Nigeria, given the African culture, how do you manage your patients' healthcare? For example, the culture of silence.
Thank you very much. I think it's more of a culture of denial
Okay.
rather than silence.
Mm-hmm.
When women develop cancer or any disease with a poor outcome,
Yeah.
the first thing in their mind is that it is not my portion. It is not for me. Uh, and they try to look for alternative sources of treatment. And in fact, a majority of the time, the patients I see
Yes.
are patients that have been managed by other people. Let me not say other doctors,
Yeah.
other people,
Yeah.
charlatans, quacks,
Mm-hmm.
juju priests, all sorts of people I've seen. So some of them, they will rub all kind of concoction
Mm-hmm.
on the breast,
Right.
which actually sometimes advance the breast because something that is not already on the skin, you start seeing that the skin is involved
Yes.
because of the fermented product they rub on the breast.
Right.
So the other things that also prevent people from accessing healthcare in time is the notion that once you come to the hospital, they're going to zap off your breast.
Hmm.
You know, uh, that's one notion that many of the patients have, and people have all kind of religious belief that when they come back in another life, they don't want to come back without their breast. So that is one factor. The other factor is that there's a belief that once you go to the hospital, you're going to die
Hmm.
with breast cancer. And this is because people come very late. If you come with advanced disease, the
Mm-hmm.
prognosis will be bad.
Right.
So all these factors make it very difficult for people to come as early as. But that doesn't mean that we don't see people that come very early. There's a rising number of people now who
Mm-hmm.
are getting more awareness,
Yes.
educated people that come earlier.
Yeah.
In fact, the slightest uh, chance of noticing any abnormality in the breast,
Mm-hmm.
they report to the clinic and ask for the opinion of the physician.
Okay.
Thank you.
Thank you very much for that. Um, We're going to have a breast cancer survivor. She's going to share her personal experience with us. She's married with 3 children. She's a blogger, motivational speaker, event host, and founder of the Pink Smile Fund. She was diagnosed with breast cancer and now cancer free. As a breast cancer survivor, she's committed to supporting and encouraging others going through the breast cancer journey. She recently had a sponsored head shave to mark her 50th birthday last month to raise funds for the Primrose Car Service and the Pink Smile Fund. Um, she also has a GoFundMe, which we'll talk about later. Please join me in welcoming Flo Aderoju. Hello, Flo.
I am. Thank you.
With Flo, it's so interesting. I actually saw a clip that she posted on YouTube, and I saw her hair being shaved off, and I thought this is very un-African for her to have done that. So tell us briefly about your journey with breast cancer. How old were you then, and how did you receive the news?
Yeah, so my journey, it's quite recent. I was diagnosed with breast cancer just last year in April 2019. How did I find out? I noticed a lump, and I just mentioned it to my husband, and he said, "Oh, it's good to check it out. Let's not take anything for granted." Obviously, when you see things like that, you never think, it's anything. But I was also having other hormonal issues at the same time. So I actually went to the hospital. I live in the UK. I went to the GP for the hormonal issues. And then I remembered and I mentioned, oh, I had actually noticed the lump. But that first appointment, they actually didn't check it, I have to say, and said to me, just wait till all the hormonal issues, when those pass. So I think they probably linked it to, what issues I was having then. But what happened, which was quite unusual, because as has been said, you don't feel pain, when you have cancer or anything. But for some reason, I started feeling some excruciating pains, not really at that point, at that side, but it just goes right through, like my chest. And I just won't be able to move or do anything really bad. And after that happened like 3 times, I went back to the hospital and I said, I actually mentioned seeing a lump. This has not been examined and I would like it checked out. And it was at that point they actually said, have you had a mammo before? I said I hadn't. I was 48 going to 49 in a few months at that time. And so I ended up going to the hospital, had the mammogram done. Initially, when the doctor even saw it, he thought it was just breast tissue. I had the mammo done. They saw some dark spot there and said I had to go in for a scan immediately. I had the scan done. And right there, again, I was told I had to do a biopsy. I remember thinking at that point, biopsy, because obviously biopsy, you link it with, stuff like this. But I had the biopsy done, and then I had to, it was a waiting game then. I was given an appointment for a week after. I think it was postponed to the next week. And so 2 weeks later, I just went into the hospital, not expecting that news, obviously. And I went with a friend, a close friend did insist that she will go with me, which turned out to be a really good thing that she did. I kept telling her, you don't need to go, but she said, I'm going to go. And I was given the news. First of all, I was given the news in quite a funny way, because there was a bit of a mix-up. I got there and they felt that wasn't the consultant I was meant to see. So someone else came to see me, and he started by saying, I guess you would have been told that it's probably cancer. And I said, no one said that to me. But at that point, even I didn't think it was. So I thought he would say, oh, well, it's not. But he said it is breast cancer. It was a shock, to say the least. I was literally speechless. And I just kept smiling. And I was just looking at him and he was saying everything. So the breast cancer, he said it had been caught early. Immediately he had said I will have to have a surgery done. Depending on the results of the surgery, I might have chemotherapy, I might not, and whatever the results, that I won't have radiotherapy. And right away they brought out the forms to fill for me to read, and I had a date already for the surgery. To be honest, I don't think I was really hearing a lot of what was being said. My friend was asking the questions, she was reading the forms, and obviously I just signed it and said, well, yeah, that's it. So that's how I got the diagnosis. It was hard for me then because I had lost my mom just 9 months before and I was still grieving, so getting that again was like, wow. So that's how I got that diagnosis.
So was there any history of breast cancer in the family?
No.
Not at all?
No history of in the family, in terms of, because each time I talk to the doctors, they say family is your mother or her siblings. That's like immediate family. So yeah, no.
So how did you break the news to your family?
I think that was really, really difficult for me. And obviously my husband was there. He called me and said, how's everything? In a normal Christianese, I said, it is well. was happy. I was like, oh, great. Obviously, I couldn't tell him over the phone. So I got hooked. I was thinking, how would I tell my siblings? Because my mom, they were still giving me, how will I tell my aunties? And I thought, I don't know how I'm going to be able to do that. But my husband came home, and I eventually broke the news to him. He was stunned, to say the least. He was shocked. He just sat there looking at me and saying, is this real? You know. And I just started to trying to say all the positive things. Oh, it's treatable. It was caught early, blah, 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 blah. I didn't tell my siblings till about 3 days later. It was really difficult for me. But I must say, on that day, which I think is one of the unusual things we're saying here, because what happens mainly with Africans is we sort of keep it to ourselves, and there seems to be some stigma around it, you know. But I'm really happy and I'm glad that didn't happen with me. And that same day, I actually set up a WhatsApp group with 12 of my friends and said, this is what's happening. I would like you to support me in prayers and just support me. And I think that was one of the best decisions I made. And the support makes a difference. And yeah, I had that support. And then I was able to tell my siblings and my aunties about 3 days later, which was difficult. But again, the support was amazing. And that was helpful.
So when you say the support, does that also, I mean, apart from the family support, were you given counseling as well?
No, I wasn't given counseling. I think it's Dr. Ogedengbe who had said that when you get the diagnosis, immediately after you see the doctor, you go in with a breast care nurse who explains everything to you, talks to you about it. You have their contacts, you can contact them. If you have any issues, they will call you sometimes to see how you're doing. So yeah, in terms of that support was there and accessible to me if I needed it.
And of course, your faith actually helped.
And I think that was a major factor in that I am a Christian, I'm born again Christian. I stood on my faith. But I need to say here, which again is really important. Yes, I'm a born again Christian. My faith was a big part of it, prayers and everything. But I still went through my treatment. I had my treatment. I think this also goes, hand in hand. I stood on my faith, but I went through my treatment. I had the support from my friends and my family. They were sending me scriptures, praying with me. I myself was standing on, the word of God concerning what I was going through. And that helped me. I must say one particular scripture that helped me was a merry heart doeth good like a medicine. And I think I always say that this condition for me, maybe being a Christian, I say two things are important to me. The first one, prayer, but the second, your state of mind. Your state of mind when you have this kind of diagnosis is so important. It can make or break. And that's where, support also comes in. It's about, your state of mind. If you're really down there in the dumps, and I guess a state of mind also that prevents a lot of people from coming forward in this already. They have breast cancer and it's like, oh, that's the end, That's it. Oh, that's it. Breast cancer is not a death sentence. That is my thing and my message, it just isn't. And the earlier you speak out about it, the higher your chances of survival, because then you can get help, you can get treatment. That's really what I'm about.
Oh, fantastic. Because you more or less answered the question I had for you, because you said for your 50th, you had a fundraising event on YouTube, which was exactly what I actually saw before I contacted you, tagged Flo's sponsored head shave. And then you also set up the GoFundMe. What was the reason for setting up the GoFundMe?
Okay, so after my diagnosis and my journey, so I had two surgeries. I had a lumpectomy, not a mastectomy. The first surgery still showed that there were unclear margins and they had to go back in, and I had another surgery. And after that, luckily, I didn't have infected lymph nodes. So because of that, I didn't actually have to go through chemotherapy, but I did go through radiotherapy, where I had 15 sessions going to Addenbrooke's in Cambridge every day. After my journey, I had a passion now to support those going through, breast cancer. I have two extremely close friends who supported me during my time. They were fine. And today they're having breast cancer treatment. One of them has actually finished it. They were fine then. So it's real, it's rampant. And I set up a Facebook group, also a support group for those who had gone through breast cancer. It was after my journey that I started my blog, just sharing my journey. And it's all about coming out and letting people know, well, I have been through it, but here I am standing. So there is hope there. It's not the end of the world. Yeah. And even though I didn't go through chemo, because I said I support quite a few people going through the chemotherapy journey, and I do identify with the thing, and I know what I went through with, my whole journey. And I was passionate and became committed to being a form of support. And I find out that, as I said, even in Nigeria, because of the way things are, I met through my Facebook group a Nigerian lady who had been diagnosed with breast cancer and had financial challenges. She couldn't do her treatment. She started it, had to stop it because of a financial challenge. And I raised funds through some amazing friends of mine. And with those funds, she was able to do her chemotherapy treatment. She was able to have a radiotherapy treatment. I mean, recovering now. And I thought, if she didn't even have access to that, what would she have done, or where would she be? So I decided that I wanted to set up a fund. Yeah. And it's not just Nigeria. I have a friend here in the UK who obviously she had quite a few surgeries. She had her chemo, her radiotherapy. She had used up her sick leave, her annual leave, everything. And she had to be signed off work. So she didn't have money. She had to go to GoFundMe. So that's why I set up the fund. Twofold. One, the Primrose Care Service. I feel it's an amazing service. These are people, it's under the Bedford Charity, volunteers, not paid for it. They come pick you up at home, take you all the way to Cambridge for your treatment, wait for you to finish treatment, bring you back home and take the next set of people in the afternoon. I was absolutely blown away by that. And it was right back then I knew I was going to raise funds for that service to give other people the opportunity to have access, to that and let that keep going. Because I don't know how I'll actually be able to do my radiotherapy treatment if that service wasn't there. So I'm raising funds for the Primrose Care Service. And then the second bit is what I've termed the Pink Smile Fund. And this is access for people going through the breast cancer journey. And for me, it's about direct impact. So very little things, because people go through so much emotional trauma. So very little things. Someone, has lost her hair, the person a week. Little things like someone has gone through the treatment and sponsor the person to a spa retreat, things like get 10 people going through the journey, go and eat out and just be able to talk. So that's what, that fund is for. And of course, people who actually need financial support. So I decided to, shaving my head. I know a lot of people were like, it's not Africa. And I'm like, well, it's not about that. It's what I want to do. And it's my passion. And the truth is, if I did go through chemotherapy, that wouldn't have happened anyway. So I did live head shave, which was live on Facebook. And honestly, the response, has been overwhelming. I have the GoFundMe still there. It's up for a month and hoping, to meet and even surpass that. Yeah, so that's why I did that. So that's why.
Yeah, really snazzy. I like it. Thank you so much for sharing your personal story with us. And, talking about support, the next speaker, she's actually an engagement lead for Macmillan Cancer Support. Macmillan, as we know, is actually she will tell us more about it, is a national cancer charity providing practical, medical, and financial, plus emotional support to people who have been diagnosed with cancer, affected by cancer, and providing support for family members and carers. She's the engagement lead, like I said. In her role, she ensures people living with cancer are involved in the design, development, and review of cancer services and support across London to improve people's experience of cancer care. She works closely with BAME, that is the Black Asian Minority Ethnic Group, so as to address cancer care and healthcare inequalities within these communities by challenging taboos and stigma that prevent people from accessing cancer support, increasing cancer knowledge within BAME communities, raising awareness of local and national support available for people living with and affected by cancer. And she also, like I said, works with BAME people living with cancer to co-design culturally sensitive cancer support services. Welcome, Emma Quintal.
Thank you, Anne, for the introduction.
Thank you, Emma. Now, let me ask you this question. You mentioned something here that Macmillan, that the work in co-designing culturally sensitive cancer support services. What does that mean?
Well, if I explain a bit about my role and how I work with the Black and minority ethnic groups across London.
Okay.
So, as an engagement lead, my role involves engaging with people living with cancer, but also those affected by cancer.
Right.
To understand their experiences, hear their stories,
Yeah.
and use that insight to improve cancer care
Right.
and redesign services.
Mm-hmm.
I work closely with the Black and minority ethnic communities, mostly because we have evidence to suggest that those from Black and minority ethnic groups experience poorer cancer care than those that identify as white British. And therefore, there are some health inequalities there that we need to address.
Mm-hmm.
There are many different reasons for that, but there are some cultural barriers that prevent people from accessing the support and care that they need.
Mm-hmm.
So I work closely with BAME communities and faith leaders to
Right.
increase education, cancer information within that community,
Mm-hmm.
but to work with them to challenge some of those taboos and stigma that prevent people from talking about cancer and accessing the care and support that they need.
Right. So when you mentioned that you work with faith leaders, what exactly do you do?
So faith leaders, whether that's a priest or imam or rabbi, have a lot of influence in their community.
That's
They're
true.
well respected and they're really trusted. Now, I'm never going to be representative of the 100+ languages we speak in London. It's really hard for me to embed myself in all the communities and for them to trust me.
Mm-hmm.
However, what I do is work with those trusted leaders in the community
Mm-hmm.
to upskill their cancer knowledge and
Right.
get them breaking some of those taboos with their community members. So when they're hearing mistruths or incorrect information, they can challenge that and
Yeah.
they can get people talking about cancer and increase awareness and support within their communities.
Okay. So, briefly, what could you just explain co-design culturally sensitive cancer support services? What does that mean?
So we know that there isn't a one size fits all for services. We need to tailor services to the communities, the diverse communities that we work with. So, for example, we've had some feedback from some of the Black and minority ethnic groups to say that they don't feel that Macmillan is for them because when they look at a leaflet, they just see white people on there and it's not tailored. So it's small things like that that we do working with groups to ensure that everything that we produce is tailored to that group. We offer interpretation and translation services. Whenever we're designing new services, be it our direct services with Macmillan or our partner organisation such as the NHS, we ensure we have Black and ethnic minority representation around that board meeting that they influence how that service looks and feels.
So, another thing I want to ask you is that what frameworks do you have in place to challenge these taboos, these myths? I mean, I deliberately read them out earlier on because these are some of the things we hear all the time. I mean, I'm sure you like somebody like Flo. She's actually Pan-African. She's very open. But then you have people who are so religious. It's not my portion. And you could see that. It's nobody's portion, but lady, you do have cancer. How do you address people like that? Or if they
Well,
say, that they're taking herbal remedies, they just don't want to speak to someone. They have this culture of silence. They don't share information. How do you break that barrier?
Well, like I just mentioned, we do work with trusted organisations within the communities, not just faith leaders. We would look to partner with organisations such as yourself, and so with RAM, because you
Yeah.
are trusted within your community and they listen to you.
Hmm.
So by increasing your cancer knowledge and giving you the skills and confidence to challenge those taboos, they are
Hmm.
probably more likely to listen to you than they may from someone like me, for example. So
Right.
we look to upskill people that are trusted within the local community. Now, around alternative therapies, no alternative therapies have ever been proven to cure cancer or even slow the growth. It's not something that we advocate, but we hear it in the community. And
Mhm.
what we say is really that's a discussion to be had with your clinical professional, your doctor, your nurse. If you're seriously considering alternative therapies, that needs to be a conversation with your clinical professional.
Right. There is one question I wanted to ask, and I'm still going to ask the question, and that is, at times when they talk about clinical trials, do you usually get a lot of Africans putting themselves forward?
So clinical trials is medical research studies involving people.
Yeah.
And often people that have cancer might be offered a clinical trial as part of their cancer treatment. Now, this doesn't fall under the remit of Macmillan or
Yeah.
something we necessarily get involved in,
Yeah.
but this would be a discussion between that patient and their clinical professional or doctor, who would suggest any clinical trials that might be appropriate to them
Mhm.
and talk through some of the benefits, but also the risks associated with that. So maybe this question might be better suited to one of the clinical
To
professionals on the panel.
Yes, I know, but the reason why I asked the question is that I've had some friends who have been through this, and they say, "Oh, they gave me the wrong medication," and I'm like, majority of the time, when we don't put ourselves forward for medical trials, how do they know what is suitable for us? I mean, we heard from Professor Adisa, who was talking about Nigeria. So how do we put ourselves forward? How do we know the kind of medicines that's good for us? Do you encourage them, when you offer this support, do you encourage them on this level? I know this question should be directed towards the oncologist, but I'm just saying, when they come to you during the support and you're talking to them, maybe you might even get a researcher coming to meet you. Do you see them offering themselves for
What
research?
what we always do is encourage people to ask questions. Go to your clinician with questions, and if that's something that's of interest to ask your clinician will talk through any possible research trials that might be appropriate for you.
Mhm.
That's probably all advice I can give at the moment, perhaps.
I just want to again dispel the myth. Macmillan support is not for Caucasians.
It's for everyone. So cancer does not discriminate, as we know. It can affect everyone, regardless of gender, age, race, religion, background. And therefore, Macmillan Cancer Support is there for everyone. It's a free service for everyone.
Okay, so that's a myth.
It is, yeah.
It is. I'm asking these questions deliberately because
No,
people have it at the back of their minds all the time.
but Anne, yeah,
Yeah.
you raised a good point, because it's something we've heard in the community, that Macmillan is a white person's charity, and
Exactly.
because they walk past the Macmillan Cancer Information Centre and see that it's staffed maybe by white volunteers, or maybe it's white people on the front of your booklet.
Yeah.
That's something we're working very hard to change, and that's why part of my role is to find people just like Flo, who's amazing, recruit them into giving us their stories and suggestions for change. How can we improve services so that
Right.
you, from the African community, know that we are here for everyone and our services are for you?
Okay. Thank you so much for that, Emma. We
You're
hold
welcome.
it right there in the interim. The last but not the least member of the panel is the founder and chief executive officer of Care Organization Public Enlightenment, otherwise known as COPE, based in Nigeria. Excuse me. Prior to establishing COPE, Ebun worked in the financial services industry. She's a Nigerian healthcare professional with 25 years experience in advocacy, breast cancer outreach, and community awareness. COPE has partnered with several Nigerian government parastatals, individuals, and organizations, both at local and international levels, regarding breast cancer programs to support breast cancer patients and survivors. Welcome, Ebon Anozie.
Thank you, Fumi, for having me here.
Thank you, Ebon. Thanks for coming on board. Now, you've been involved with COPE for over 2 decades. What made you establish such an organization, given the African perception of cancer?
In 1970, I lost my mom to colorectal cancer. And in 1995, I lost my father to cancer of the stomach. And I had a scare as well in 1995 when I was in America on vacation. So I went to have it checked and I was declared free.
Right.
You know, so I now decided to come back home and do it on a part-time basis. And I found out I couldn't do it on a part-time basis. You know, people were urging me to come and set it up and be there permanently. So I had to do that. So that's my story.
That's your story. Thanks. So, how have you been able to break the culture of silence in Nigeria?
It hasn't been easy because I also remember when I started talking about breast cancer, I noticed that a very good friend of mine had a lumpectomy done, which she didn't even talk about.
Right.
You know, so I told her that, look, this is what I want to do. Let's let Nigerian women know about this problem, because a lot of people are not coming out. When I came out, I was chastised for coming out to talk about breast cancer, touching my breast, showing people how to do it. You know, it was a difficult period for me at that time, but luckily people have embraced it. And with what we're offering here, we have a lot of people who come and have their breast examined. So it hasn't been, it's been a fulfilling journey, but not that easy, trying to get women to still come and have their breast checked.
Mm-hmm. So what type of support do you offer the survivors or breast cancer patients?
You know, it's always very traumatic after you have been through that ordeal. Mm-hmm. Because Flo, I must commend you. I must commend Flo for that. You know, it's not an easy journey. What we do at first is allow them speak their mind, say their story, mm-hmm. you know, bring out the best in them, make sure that they're willing to talk about what they went through, because you can't really push it out. No. You have to let them flow with other people. What we have in our group, they call themselves One Nation, you know, bearing in mind that they all have one breast. And we let them have the prosthesis. We have the prosthesis, which is right behind me here, the bras. Mm-hmm. We give them that. We let them regain their self-esteem, right, and be able to talk about how they feel. Mm-hmm, mm-hmm. A lot of them had stories to tell. Right. You know, coming to the support group, how they were treated in the hospitals. You know, the doctors not following the rule of spikes, mm-hmm. and we have to do that from the beginning to reassure them that everything is going to be fine. And then we also encourage the family members to be part of the group, mm-hmm. you know, and we encourage them when they go for their clinic and to see their doctors, to invite other women to come for the support group as well. Mm-hmm, mm-hmm. And most importantly, we invite a lot of professionals to talk to them. We have the motivational speakers who come. We have the exercising expert. We take them to the spa. Mm-hmm. We have quite a lot of programs that we offer them, and they're always very comfortable. And we have my vice president, who is a breast cancer survivor. It's about 20 years plus now. And it's encouraging for people to see that you can survive breast cancer if detected early, which is the key thing that we also talk about. Mm-hmm. And then it's also important that they now teach their own children, the mm-hmm. female children, the mm-hmm. essence of early detection. Mm-hmm. Mm-hmm. So that comes to play as well.
Mm-hmm. You know, over in the UK here, there's some cancer charities that they go to universities to talk about breast cancer at a very early age, that to check themselves. Do you have something similar like that as part of your educational programs?
Yeah, we go to schools, we go to secondary schools, we go to the universities, we go to churches, mosques, we go to organizations, profit-making organizations to talk to them. We go to marketplaces, and then we have the screening machine here. We have the screening done every third Saturday of the month from 10 a.m. to 2 p.m. A lot of women come. And we also, for screening with the breast ultrasound scan, and we have the doctor and the nurse. The nurse does the clinical breast examination.
Right.
And we have the wall of fame that we use in encouraging organizations to buy into. They support 333 women each every year to come for breast screening. Right. We also have students who come here for their educational, what do we call this thing that they do? It's more like a group thing. They come here to get more information using our Breast Cancer Information Service Center, which is a library.
Okay.
We have a lot that we offer quite a lot of people.
Interesting. How responsive are organizations to funding breast cancer programs, given the African mindset and the perception of NGOs?
Organizations are always they're willing to help us. We have quite a lot of organizations supporting COPE because of the transparency.
Yes.
You know? And we just acquired another machine recently by an organization, Leadway. You know, we have machines that we can comfortably screen 400 people in a day.
Wow.
With the machines we have. Yes, we have about 4 or 5 machines that we use. So we encourage women to come whenever they have a problem, bearing in mind that on Fridays is a counseling day. Right. We open it up for women to come and talk to us if they have private issues. And we also have organizations that sponsor some of these breast cancer support, breast cancer patients, those who are not, who don't have the wherewithal to continue their treatment. So we do that as equally. And then we support caregivers as well. Right. We give them financial support so that they don't worry about having to go looking for funding. That's when the funds are made available to the organization.
Thank you so much for that, Ebo. But what about the breast screening service? Is it free or they have to pay?
It's heavily subsidized. It's just 3,000 Naira. Oh. That's what they pay. Yes. Oh, okay. Because if you were to go out, it's about 15, from 5,000 to 15,000. So here is heavily subsidized.
Okay. All right. Thank you so much for that, Ebo. I have some questions which I will quickly take from the chat box because we seem to be running a tad late. Somebody's actually posted here. We often notice that from the very moment diagnosis is made, is it true that because of the mindset of knowing could make the rapid development of cancer cells to increase? Or what contributes to the rapid and aggressive growth of the cells? Yeah, I think I'll take that question. What contributes to the rapid and aggressive growth of the cells? Do you want to take that, Dr. Sirohi?
So I think every cancer has its own biology, and in breast cancer broadly we talk about 3 types of cancer. One is the hormone driven or the estrogen receptor positive breast cancer, which is not very fast growing. Right. The second is HER2 positive or triple negative. These are just types of breast cancer. Mm-hmm. And so the aggressiveness is decided upon by the grade of the cancer, how it looks under the microscope. Right. And that is decided by how fast the cells are dividing.
Okay. All right. I'll take the question that I asked Emma earlier. I would ask you, Mr. Ogedegbe, do you encourage Africans to put themselves forward for clinical trials? Because you know the reason why I asked that question. I remember you said to me, and I roll it with what Ebu mentioned. Is not until when the person is ready to actually share the story or want to talk about it. When I was looking for someone to share their personal story with us, you mentioned that there is a lady who was going to share, and I think I have an idea who the lady is, but she has to be in a good place before she comes out to share. So the thing is, and this particular person I'm talking about, she puts herself forward at times when she's in the mood. So do you encourage uh, these women to put themselves forward for clinical trials so that they know
The,
the better medication?
the clinical trials are a very good thing. And without clinical trials, we would not be in a position to talk about the various types of breast cancer.
Yeah.
Estrogen receptor negative, estrogen receptor positive, HER2 positive, triple negative, genetic related breast cancers. So trials are essential. And without trials, breast cancer would not be where it is. Of all the cancers that are available, breast cancer has the largest amount of trials that have been done. And trials are categorized 1, 2, 3 to 4. And what we try to do in breast cancer, most of our treatments have been designed based on meta-analysis of randomized trials. That's the highest level you can get.
Right.
Okay, so when a patient comes into your clinic room and you've made a diagnosis of breast cancer, fortunately, more often than not, most cancers can be treated easily without trials. Now, the difficulty is when you get to the end of treatment. So you've had chemotherapy, you've had radiotherapy, you've had hormone therapy, you've had surgery, and the cancer comes back either in the breast or somewhere else. And you seem to have run out of the usual drugs. Then trials become important. So at the outset, we would not talk about trials for that sort of disease, but there are various other trials. There are surgical trials, there are medical trials for chemotherapy, there are radiotherapy trials, and there are trials for endocrine therapy. So we tend to feed our patients into the various groups. When it comes to patients from Black and ethnic minorities,
yes,
it is very difficult to get them recruited into trials. Because the mindset is that you're going to use me as a guinea pig. Now, which is the wrong mindset? Because if there are no trials, we would have no treatments. We had to treat so many patients and enroll them into trials to come up with the treatment plans we currently have.
right.
And we also know, we've talked a lot about, I don't know if it's been echoed enough, we've talked a lot about triple negative breast cancers, which are more common in Black women, and especially in young Black women. And triple negative breast cancers do not have a good response to treatment. And there are currently 2 or 3 trials which are running for triple negative breast cancers to identify if there are certain medicines called PARP inhibitors, which alter the DNA structure, might be effective for this patient. And so it's important that when our patients come, not only should they be open to having the standard treatment, but they should also be open to trials. And I encourage all the patients who come into my clinic room to enroll for trials. And we know that Professor Adisa has mentioned, which is correct, that young Black breast cancer patients have the worst outcome amongst all breast cancers in the world. And those are the ideal group of patients who should be recruited into trials to try and find a solution to this sort of dilemma we have in trying to treat, especially when we say young, less than 40-year-old Black women who have a very, very, very bad outcome, where we are dealing with the combined twin problem of having patients who, 1, have a bad biology, and then 2, may not have good access to treatment. And even when they do, they default. So you can see the variety of problems that coalesce to try to affect and determine poor outcomes for Black patients. So having your treatment when it's offered, being available to have trials is very important. But I have to say that when it comes to trials, institutions and organizations need to be a bit more flexible in making it not just available to Black patients, but making it attractive to Black patients for their various ethnic and cultural hang-ups. Because if we don't address those things, I think it will even be more and more difficult to get Black patients to get involved in trials.
Wow, fantastic. Thank you so much. That will probably, we will take that as your final message on this discussion program.
No, my final
Okay.
message. No, my final message. I don't think I can go with that. My final message are twofold. For Black patients who live in the United Kingdom and the US,
Right.
please go and see your doctor. Keep your clinical appointments. If you're offered treatment, please have treatment. And screening mammography is free, at least in the United Kingdom, from ages of 50 to 75. Avail yourself of that opportunity and get your screen done regularly. For our patients in Nigeria who have many issues, they don't have a good access to care, and there's poverty, and there's ignorance, and there's absence of proper health of proper healthcare professionals. The lady Ebon has just the lady from COPE has just mentioned it. Clinical breast examination is important for a young woman. A week before your period, a week after your period, that's ladies over 40, under 40, and for the older women, identify one day of the month to examine your breast. If you find something wrong, please start with a doctor, not an imam or a pastor or a native doctor, please. Thank you very much.
Thank you so much for that. And what about you, Emma? A final message for us here?
Yeah, so a final message for me would be if you're a person living with or affected by cancer in the UK, Macmillan are here for you. We're a free service and we're here to serve everyone affected by cancer in the UK. For those of you that may be joining us from further afield, please use the information and insight that you've heard today to challenge some of those taboos within your community, get people talking about cancer and accessing the support and care that they need.
Thank you very much for that. Dr. Sirohi?
So my final message would be exactly what you're doing, is to discuss and talk about breast cancer, because this is how we are going to remove the taboo and the stigma associated with breast cancer. So I congratulate you at what you're doing. And I would urge women to seek help promptly, whichever part of the world they are in, if there is any issue related to not just the breast, but anywhere.
Thank you very much for that. And Ebon, final message?
My final message is for women to realize that breast cancer is no one's portion. So kindly avail yourself to monthly screening. It is very key. Early detection can save your life and your breast.
Okay. Professor Adisa, your final message, please.
Can you hear me?
Yes.
My message is that the diagnosis of breast cancer is not a death sentence.
Mm-hmm.
People should be aware that if you come early, you get very good outcome. I have several of my patients who have had mastectomy, who have had diagnosis for more than 20 years, and they're still doing very well. So we want to encourage them that if they come early and they go to the appropriate personality, not just to go to any quack or charlatan, the chance of detecting the cancer and treating it promptly is much higher. Thank you.
Thank you very much. Finally, Flo, your final message for us.
Yeah, I think most people have said it. My message was breast cancer is not a death sentence. Breast cancer, that you have breast cancer doesn't make you less a person of faith. I mean, God has also created those people who are helping us. So you can stand in faith and also continue with that. And also, the earlier you speak out, the higher your chances of survival. So this speak out, talk to someone. And also, I think on the flip side, people should try and support people with breast cancer so that they don't see it as, you know, a stigma. There should be no stigma around breast cancer. Please, to encourage people to speak out.
Thank you so much for that. Somebody just quickly posted something and I need a very quick answer. Dr. Sirohi, Does breastfeeding actually cure breast cancer?
No, it doesn't. But if you breastfeed, it decreases your chance of getting breast cancer. Yeah.
Okay. Thank you very much for that. I'd like to thank you, all my guests, for coming. Professor Wadisa, Flo, Ebon, Anozie, Dr. Bhavna Sirohi, Mr. Ogedegbe, and of course, every participant on board here today. I'd like to give you a very, very warm, and I don't know, because I've been so blessed having people here on board today. This is a Saturday evening. Thank you so much for coming.